Good afternoon, distinguished guests, esteemed colleagues, ladies and gentlemen. It is a great honor to be here at the ISAMS 2025 conference in Busan. My name is Dr. Vincent. I'm currently the Commissioner for Chinese Medicine Development for the government of Hong Kong SAR, China. Today, I'm delighted to share with you the journey, current state, and future aspiration of Chinese medicine services development here in Hong Kong. So we will cover a brief overview on Chinese medicine services landscape, our pioneering work in integrated Chinese and Western medicine, and also our robust framework for ensuring patient safety in this presentation. So a vast majority, a striking 96% of Chinese medicine consultation is actually provided by the private sector, predominantly paid out of pocket by our citizens. And this reflects a very high and also deep-rooted demand of Chinese medicine services in our daily care in the Hong Kong population of 7.5 million. And conversely, in the public tax-funded system currently, provide only about 4% of the services, but we offer a varying level of subsidies to make Chinese medicine services more accessible for a specific segment of our population, such as very low-income families. So this dual system of public-private mix presents both challenges and opportunities for integration and development. So let me introduce our public healthcare system, which is the public sector. The name of the public healthcare system is called Hospital Authority. Despite the name is about the hospital, but actually this authority has a lot of primary care and specialist outpatient clinics as well. It's a statutory body that manage all the Hong Kong's public hospital and related healthcare services. Interestingly, despite the fact that majority of the private TCM services is provided in the private sector, all the inpatient services of Chinese medicine and integrated Chinese and Western medicine services is provided in our public hospital. And more than 90% of the inpatient services is actually provided by our public sector. So the cornerstone of our public Chinese medicine strategy is the establishment of 18 Chinese medicine and training and research centers throughout our territory. We have 18 districts in Hong Kong, and for each of the districts, we will have a Chinese medicine clinic and training research centers. They are not only clinics, they are triple-purpose hubs. They provide essential clinical services with our annual attendance of about 1.6 million. They are the centers of training for the next generation of Chinese medicine practitioners and researchers, and they are also the operational base for our integrated Chinese Western medicine program in our hospital wards. So this clinic training research model ensures that service delivery is continuously informed by evidence and professional development is ensured through the cooperation of different parties. So these 18 clinics are actually operated collaboratively with our three schools of Chinese medicine and also our community networks to ensure that the service outreach is sufficient. So we have actually increased the subsidized service quota for the lower income families from 600,000 to 800,000 recently to cater for increasing needs in the public sector. And also in the wards of our Western medicine hospital, 26 of them currently offer integrated Chinese and Western medicine collaborative services, and that actually adds up to 67 hospital wards in Hong Kong, and we focus on disease area where integration actually has more advantages. And more importantly, the very first Chinese medicine hospital in Hong Kong will be commencing services by phase in 11 December this year, and the grand opening of the hospital will be held later this year. So this is the first TCM hospital in Hong Kong, and our Hong Kong government has actually a full control on the hospital, but the operator will be the Hong Kong Baptist University, which is one of the schools of Chinese medicine in Hong Kong, although all three schools will be cooperating as well to ensure that education and also the research will be centered all in this one big hospital, which is the flagship infrastructure here in Hong Kong. And we will still provide government subsidized services for our citizens that will represent 65% of the total service volume, and the remaining will be private services. So this hospital will have general outpatient clinic, referral clinic, which actually specialize in certain diseases that can be managed in outpatient, but TCM has a special advantages, and also daycare center as well as 400 beds for the inpatient wards. This will be a challenge for Hong Kong because this is the first time that we scale up all the services that we are currently running in the past 10 years in a public Western hospital. But now the TCM doctors in this hospital will be in charge and extend the service beyond our Western hospital. And interestingly, we will also have a clinical research center there, including a phase 1 clinical trial center, such as to cater the industry R&D development as well. So now we will focus a bit on the integrated Chinese Western medicine services in the hospital authority, which is a precursor for our inpatient services to be held in the Chinese medicine hospital in Hong Kong. So recognizing the community needs in inpatient Chinese medicine services, we try to synergize the potential for both medical system, and our public healthcare sector actually launched this program initially as a pilot program 10 years ago. And this pilot program has been regularized and expanded last year. And now we are increasingly expanding all these services to cover more hospitals, including our Chinese medicine hospital, and on a wider range of medical conditions. So the scale of its integration is growing rapidly. As of September 2025, our service is operating, as I mentioned, in 26 public hospitals, and we have recently more than 80,000 patient encounters. And we focus on designated disease areas, including stroke care, pain management, cancer palliative care, and we just extended also to cancer care, respiratory care, specializing in COPD management, and also knee OA care as well. So how do we create such a model? We actually put the Western doctors and the Chinese doctors into the team. So they discuss, based on current evidence on efficacy and safety, clinical management protocol that is agreed with each of the teams, and then is the best for the patient. So we have the best choice for the patient when we determine whether a certain patient should be receiving Chinese medicine on top of Western medicine in a Western medicine hospital. And of course, we have to collaborate with other higher professionals and nurses, so especially in areas like stroke rehab. So Chinese doctor and Western doctor, they will have joint patient wants and assessment with clearly defined role for each discipline. So we actually clarify all the legal implication and responsibility for each of the parties, so they can collaborate with a lot of confidence, because they know that there will be legal implications for the protocol, so they agree before they actually implement it. And then these will provide the patient with additional treatment option, and patient can choose whether they want additional Chinese medicine or not in the Western medicine hospital. And there are 3 pillars of success when we roll out this TCM service in Western medicine hospital. So first of all, we need a very strong and structured corporate and clinical governance structure. And this means that we engage a multidisciplinary stakeholders, including the high management, top management of our hospital authority, Western doctors, TCM doctors, to work together to develop the whole program. And patient safety is always our top priority, and we will talk about it a bit more later on. And the hospital authority develops clinical practice guidelines for potential herb-drug interaction as well as herbal medicine adverse event, and how actually TCM intervention can work safely together with conventional Western medication. We are using an evidence-based approach for managing this risk, and I will introduce later. And also, of course, we will follow evidence-based approach and create an integrative care model that put together not only Western medicine doctor, but nurses and allied health professionals as well. And we facilitate seamless health record sharing in the hospital. So the Chinese doctor can actually look at all the records, okay, of the patient in the Western hospital. So they work together without any information block. So why do we believe in integration? Because we know that the global prevalence for using Chinese medicine is very high in many of the populations. It's about 80% of the population in over 170 WHO member states. And in Hong Kong, almost 100% of our population uses some TCM services over the year. And we know that the concurrent use of traditional and herbal medicine and Western drug is very common. According to a systematic review, that can range from 5 to 88% in older adults around the globe. And we know that in Hong Kong it's also very common. So we cannot just turn a blind eye to this issue. And we decided to manage it proactively when we deliver our service. So in order to cater for the further development of our hospital, as well as the ICWM program in a Western hospital, we established the ICWM Treatment Safety Center in our hospital authority. And the main objective of the center is to address the safety concern related to the administration of Chinese herbal medicine and their concurrent use with the conventional drugs, which is very common in a hospital. So we develop a very practical risk assessment framework supported by a rigorous systematic review process and an expert panel. And then we produce clinical practice guidelines that support the development and delivery of ICWM services. So we use a evidence-based and utilizing a risk stratification approach. So following a very typical systematic review process, we evaluate scientific evidence from various databases and original study. Then we do literature screening to find out important evidence from human as well as mechanism of action, because this is another stream of knowledge that will supplement our evidence, because as you know, on safety and herb-drug interaction, most of the time we don't have evidence from randomized control trial or even decent cohort study. We often rely on case control study, case series, or even single case report. So when we look at the causation between adverse, harmful, HDI or adverse event, when we look at the causation, we really have to look at the mechanism to action in order to make us more confident when making certain recommendation. And that is, of course, has to be clinically oriented because we want to change the decision of the practitioner and the doctors. So far, we completed systematic review of approximately 232 Chinese herbal medicine and formula, which is commonly used in our ICWM clinical protocol. So we need trust and buy-in from our frontline clinicians. That's why the governance part is really, really important. We have a multidisciplinary expert panel in the center, led by a pharmacist, a toxicologist, clinical pharmacologist, Western doctors, Chinese doctor, and also university professors. And usually, one of the expert panel member will be designated to do the systematic review. Usually it is done by the university first, and then the center staff will enhance it. But the final endorsement and the formulation of the recommendation has to be endorsed by the full expert panel and officially launch it as a recommendation for clinical practice. So in terms of methodology, we usually search for 14 to 36 international English databases, 4 to 5 Chinese databases for adverse actions, and also we purchase the 4 major databases for herb-drug interaction information. So based on the database, we will search for additional paper, okay, that answer specific questions, including more of mechanism of action information as well. And then the team will formulate a summary report for further review amongst the expert panel, and then we do assessment on the current state of evidence, and then we make recommendation on what to do in the clinic. So we have a risk stratification matrix because we have so many evidence coming from the database, from the study. So we create a body of evidence for this systematic review. And unlike doing a meta-analysis, they are very mixed evidence. You have case reports, individual case series, you have mechanism of action. So you need an overall risk stratification matrix that actually determine how confident you are when you're making the evidence. So when you have very strong design, so let's say you have a very good cohort study, very good case control study or RCT, then you have a good and strong study design, and then you look at the risk of bias for each of the study design. If they have very good methodological quality and a strong design, then the evidence tell you that there are adverse events, then you can give that body of evidence a high risk. So you make a high risk recommendation. And then accordingly, you may have moderate risk, low risk, or low reported risk. So using that matrix, we generate recommendation with very clear recommendations. So for high-risk herbs group 1, we will define at-risk patient that use of that particular herb is prohibited, or even if it's non-high risk, we will have a protocol on specific blood monitoring. So we have to monitor using ECG or blood tests to ensure that there will be no major adverse event. And these herbs sometimes should not be used together with certain Western drugs. So for moderate risk herbs, we will recommend the doctors to use alternative if possible. If specific clinical monitoring is needed, then we will specify how we should monitor and how frequently we should do that. For low-risk herbs, we will only ask the doctors to check for the specific symptoms and signs related to adverse event. And for herbs in group 4 with no reported risk, we'll have no specific monitoring needed. So you can see it's more than the evidence per se. We have to look at the severity of the adverse event. We have to look at expert opinion and the clinical experience to actually formulate these very practical recommendations. So it's a complex task, actually. So this is a very busy slide, but no problem, I will explain it to you in a more simple terms. So this is evidence profile for a herb-drug interaction problem of 位置, very common Chinese medicine we use in Hong Kong. And we find that there's a significant herb-drug interaction of this herb with tacrolimus, which is a drug, immunosuppressive drug, very commonly used amongst patients with transplants. And from the database, herb-drug interaction database, there are 2 databases telling us that actually we have to be very careful when these 2 are being used together. So we search for additional study on that, and we located one self-control study with 12 patients. And we see that the use of 位置 is going to decrease the clearance of tacrolimus, the Western drug, significantly to a level that is going to make the patient overdose in this Western drug. So we have to be very careful. We don't want to overdose tacrolimus because of the decreased clearance. And that's why when we look at the level of evidence, the severity, the risk of bias, and expert opinion, we decided there is a moderate risk if these 2 are being used together. And therefore, we recommended when the patient is using this tacrolimus Western drug, we should avoid the use of 位置 or replace it with another herb. And if the Chinese doctor really want to use it, prescribe it, then the Chinese medicine doctor has to countersign for that. So that West Chinese doctor has to take the responsibility, of prescribing this herbal medicine. So this is how we actually translate the evidence into very practical guidelines. The other example is the herbal adverse reaction of 补骨脂. And this is another very common herb used in Hong Kong. So we searched for literature for specific toxicity. We got 4 papers about the hepatotoxicity of this herb, and we got 2 papers on the potential mechanism of action. We see 4 case reports that the use of this herb actually cause acute hepatitis and abnormal indicators in liver function tests as well. So, and we know the mechanism also. So based on this evidence, we think that also there's a moderate risk of using this herb, especially when the patient have existing liver diseases like hepatitis B, which is very common also in Hong Kong. So we don't recommend the use of this herb when the patient have liver function derangement And if the use of this herb cannot be avoided, again, the Chinese doctor has to countersign for it. And then when it's being used, we have to closely monitor the liver function. So for the adverse event, we focus on 3 organ systems currently. We focus on the cardiovascular system, the liver, and the renal. So for many of the herbs and formula that we commonly use, we have come up with recommendation and risk level assessment. So for example, here in Shanqi, notal ginseng, we know that it is no good for patients, especially those with AV blocks, because that increases the risk of arrhythmia. So we do not recommend the use of this herb for all patients with an AV heart block. And so even if you're using it for high-risk patients, you have to do ECG monitoring. So we have come up with many of these guidelines already. So at the end, in our program, in all our clinics, we have more than 400 Chinese medicine granules being used, and many of them actually have safety concern, about 23% of them. So we have come up with 36 with cardiovascular issue, 33 with liver issue, and 13 with renal issues, and about 26 have drug interactions as well. And these are all being implemented as guidelines and protocol in our Western hospitals. So in the future, we'll do more reviews on these topics and possibly add more database and to cover more organ system, because we're looking at liver, renal, and also cardiovascular. Now we are going to look for CNS adverse event as well. So the way forward, we want to leverage observational study design and big data analytics to drive original study on potential adverse events on herbal medicine, because all our 18 clinics use electronic healthcare record, and we have more than 20 years of data already, but we are not using it too much for research, and we want to exploit the potential of that to uncover clinically significant findings. And in local terms, we want to create a collaborative platform internationally to establish a global forum for sharing expertise and coordinating international herbal medicine adverse event research, and also HDI research. So thank you very much for your attention, and I hope to see you sometime in the future here in Hong Kong, so we can actually advance our exchange on traditional medicine research, education, and service development. Thank you very much.